we're all very, very proud of it. I think it's a great addition to the literature and really, fulfills an important gap. So, Suzanne, I'm going to turn it over to you.
Great. Well, thank you so much. I'm really excited to be here and to be presenting this and discussing it with this panel. I'm going to go ahead and share my slides. Let's see. Can you see?
Yep, perfect.
Perfect. Love it. All right, then, we'll get started. So it really is my honor to present on the SCAI Expert Consensus Statement on Cardiogenic Shock in Women. This was published earlier this year in JSCAI, and you can see it really involves a whole slew of people, all of whom are actually on the panel or giving presentations today. So talking about the rationale behind this, cardiovascular disease related mortality rates have decreased over the past 2 decades, but the rates for in-hospital mortality for cardiogenic shock haven't really changed and they remain very high. Current evidence suggests that there are significant sex-based disparities in the timely delivery of optimal treatment for cardiogenic shock in women, and that subsequently contributes to persistent poor outcomes. We know that not only do women encounter delays in treatment, they're less likely to receive guideline-recommended coronary interventions or device therapies compared with men, independent of disease severity. And the current society practice guidelines that are out there don't really have sex-specific recommendations, and they don't highlight the instances where evidence regarding diagnosis or treatment is insufficient to optimize outcomes in women. And so this consensus statement really aimed to provide a comprehensive summary of the available evidence on cardiogenic shock in women, to identify knowledge gaps, and to suggest directions for future clinical investigation. So the methodology behind the consensus statement, the writing group was organized to include a diverse geographical perspectives as well as a diversity of specialties. We had heart failure representation, interventional cardiology, cardio-obstetrics, and critical care cardiology all involved in the writing group. The statement was done in collaboration with the EAPCI as well as the Association of Acute Cardiovascular Care. And the consensus tips were discussed and voted on by the full writing group, with consensus being defined as 75% agreement. The statement begins with a review of sex-based differences of the etiology and the presentation of cardiogenic shock. Certain etiologies of cardiogenic shock are more common in women, things like SCAD, Takotsubo's, myocarditis, when we compare that to men. And certainly hormonal differences can account for some of these observed differences in etiology and presentation. We know that estrogen has anti-inflammatory effects that can protect against cardiac cell death or oxidative damage from ischemic reperfusion injury, endothelial dysfunction, adverse cardiac remodeling. But these hormonal differences may also have paradoxical harmful effects by decreasing ischemic preconditioning in women compared to men. And beyond the difference in underlying shock etiologies, we know that clinical presentations of cardiogenic shock can differ based on sex. Women tend to present with a higher LVEF and similar, even lower rates of renal or liver failure. But nevertheless, we know that also hemodynamic studies have shown that women with cardiogenic shock, despite this, have lower cardiac index and lower cardiac power output. And so this leads to women often being mischaracterized as being clinically stable despite ongoing systemic hypoperfusion, and that can lead to delays in the initiation of appropriate advanced care. We set out to cover important data and recommendations regarding the general management of cardiogenic shock in women next. There's been growing evidence that early assessment of end organ damage and perfusion status using markers such as lactates is essential for establishing the early diagnosis of shock. And our societal and expert guidelines recommend frequent measurements of lactate levels for patients in or at risk for shock. But our studies have shown that women, and this was a study that was done in women specifically with acute myocardial infarction-associated cardiogenic shock, are half as likely to have lactate levels checked prior to PCI when compared with men. And while we all know the randomized trials of PA catheters failed to show a reduction in mortality in kind of an unselected all-comer patient population, there have been some retrospective studies that have looked specifically at patients in shock and found that early targeted PA line use prior to initiating temporary MCS, as well as PA line guided pharmacologic and MCS treatment protocols, leads to lower mortality in the cardiogenic shock population. But again, data has shown that women with cardiogenic shock are less likely to receive PA catheters when compared with men. And so our consensus statement really highlights the need for early and frequent assessments of end organ function, as well as the early use of PA lines to guide early diagnosis and treatment considerations for women with cardiogenic shock. Once that shock's diagnosed, we've seen actually that retrospective studies have suggested that aggressive escalation of vasopressors and ionotropes at the expense of delays in temporary MCS may be associated with worse survival. And that's what's shown here on the right in a sex-based analysis of the RECOVER-3 trial. It's been postulated that women may have a greater susceptibility to the effects of vasopressors, including things like increased myocardial oxygen consumption, arrhythmias, reduced end organ microcirculatory perfusion, and that could account for these findings that were observed in RECOVER-3. The problem is we know that the data behind clinical benefit of MCS and cardiogenic shock is limited in everyone, with the exception of the recently published Danger Shock trial. However, sex-specific evidence is even more limited, and that's largely due to the underrepresentation of women in shock trials. And so accordingly, we recommend early consideration of MCS in women in cardiogenic shock who are being treated with vasopressors, but still acknowledge the large gap in evidence regarding optimal MCS device selection and timing in women. We all know all cardiogenic shock's not the same, and so we then broke the document into sections dedicated to reviewing the diagnosis and management of specific types of cardiogenic shock in women, including sections on acute MI, heart failure, valvular heart disease, and cardiogenic shock in the pregnant and postpartum patient. Each section reviews the available sex-specific data for diagnosis, treatment, and there are specific highlighted consensus tips on the topics, such as, role of mechanical circulatory support, and then again, also areas where there are significant evidence gaps. While cardiogenic shock is rare in pregnancy, it is associated with high rates of maternal and fetal mortality. And peripartum cardiomyopathy is the most common case of shock related to pregnancy, and so we did focus on that here in this document. The care of the pregnant patient with cardiogenic shock obviously poses kind of unique challenges because there's a focus on caring for both mother and fetus, and that can affect medication choices, can affect use of mechanical circulatory support, procedural access, positioning, radiation exposure. And so given the complexity of these patients, multidisciplinary team collaboration among cardiology, obstetrics, anesthesiology, critical care, neonatology, it's all paramount to maternal and fetal safety. And that's really what this figure shows here, really highlighting the pillars of therapy when managing cardiogenic shock in pregnancy. The SCAI shock classification devised by Dr. Naidu, was initially released in 2019. It was updated in 2021, and it's really been key in providing the cardiology community with a 3-axis model that really integrates shock severity, clinical phenotype, and risk modifiers across both men and women. And so what we did is we tried to build upon this already existing SCAI shock classification to provide a consensus on best evidence-based practice pathways of care to optimize early diagnosis, monitoring, and treatment of women with cardiogenic shock based on etiology-specific management as well, and that's what's shown here in our central figure. But our work really isn't done. I alluded to this earlier. There are a lot of barriers to care in women with cardiogenic shock. Our studies have shown that concern for bleeding or vascular complications in women can really deter the use of temporary mechanical support, despite demonstrated improvement in complication rates in both men and women over time with techniques that we've used to optimize large bore access. And again, as I mentioned, data in cardiogenic shock is limited for everyone because it's difficult to study this disease state. There's a striking dearth of sex-specific data. And part of that's driven by what you see here. This figure shows the major cardiogenic shock trials and the percentage of women who comprise the study populations. And in most trials, women don't even hit 30% of the study population. So really, without improved targeted enrollment, it's really hard to understand the risks and benefits of existing and the novel treatments in women who have shock. So in conclusion, then, early identification of cardiogenic shock and its etiology, as well as early referral for mechanical support, is key to improving mortality outcomes in women. A standardized approach to diagnosis and treatment, which is what we detailed in our central figure, may help to reduce sex-based disparities. We need better representation of women in shock trials and consideration even of dedicated RCTs of women with shock to determine the best treatment strategies to improve outcomes. We hope that this consensus document provides a comprehensive summary of the current state of treatment of cardiogenic shock in women and should be used as a resource to guide clinical practice and hopefully ultimately improve the care of our female patients. Thank you.
Thanks so much, Suzanne. That was, once again, you're a pro at summarizing such a wealth of information. I'm very impressed. I think there's so many different things to talk about here. There's the early diagnosis that you talked about. There's the disparities. There's the lack of understanding. There's the lack of clinical studies, etc. I think I think what we're going to do is we have 3 cases. So I think what we'll do is we'll move on to the cases. Hopefully we can kind of get a little bit of discussion with each one of these cases, because I think they illustrate some of the topics that we have in our consensus document. And then at the end, we have about 10, 15 minutes, I think, for a good discussion. So why don't we plan to then move on? And I'm going to ask Mirvat, if you don't mind, if you're still awake, I hope you are, to do the first case, to present the first case. It's I just had a quick preview, and it's really excellent.
Well, thank you for the invitation to join you this evening. I'll present the first case of cardiogenic shock in a woman.
Mirvat, you're on mute. You're on mute. If you can unmute yourself and start again.
All right. Well, thank you for having me. And I'm going to present an interesting case of a young woman. She was actually 31 years old. At that point, she didn't have any significant cardiovascular risk factors other than smoking. She wasn't using drugs. She was not on oral contraceptives or anything like that. She was actually at a wedding. She was dancing, and in the middle of dancing, she started to feel a lot of chest pain. It was very acute, never had that kind of pain in the past, and was rushed to the hospital. In the emergency room, her hemodynamics were very alarming. Her blood pressure was 80/40, and her heart rate was 120 beats per minute. So I'll show you her EKG in just a moment, and this is what it was. It was massive anterior septal ST elevations. A point-of-care ultrasound clearly showed wall motion abnormalities in the anterior leads, in the anterior wall and anteroseptal wall. What was interesting here is you can see a little bit of thickening that you're seeing in the septum as well, although she had no history of hypertension or anything like that, and it was a bit concerning. The right-hand side image, you clearly see that this was a point-of-care ultrasound that was done when the patient, the cath lab was already activated, and obviously we had already started our management for this patient. So her EDP, once we got in, was 32. The initial lactate was 2.5. And at that point, her oxygen saturation and everything else was actually okay. You see her right coronary artery was essentially normal. It was a dominant vessel and looked fine. There were no atherosclerosis there. We look at the left system, and yes, it was quite concerning. She has a nice, circumflex artery with some branches and a small ramus branch. But the LAD is very concerning, and especially the very proximal ostial segment where it was suspected to be a hematoma. And then you see the rest of the LAD kind of peters down, although the other vessels like the circ on the right are actually completely normal. And so at that point, we obviously considered spontaneous coronary artery dissection in this woman and started to scratch our heads which type it is, which was really irrelevant. She was in cardiogenic shock, and she had ostial LAD disease, which meant we probably should be treating it. So at that point, we had put an Impella circulatory support device in. As you can see, her repeat blood gases in the cath lab at this point, you can see that her lactate started to creep up. So now it's 3.1. And she was still around the same in terms of blood pressure. So our strategy was put in the mechanical circulatory support device, ideally wire both vessels, the LAD and the circumflex, stent the proximal segment, plus or minus intracoronary imaging. So at that point, looking at the SCAI classification, she was clearly, she was probably already at the C, where she already has some hypotension that's quite significant, and her condition is actually worsening. Now, looking at the European guidelines for intracoronary imaging, they do afford a class 2B indication for intracoronary imaging, including optical coherence tomography for spontaneous coronary artery dissections. Although this is the recommendation in our practice, we're very reluctant to do intracoronary imaging, particularly in patients where you already have an established diagnosis. There's nothing ambiguous about the patient that I just showed you. One of it is the risk of extending the dissection, whether it's with wire manipulation or with the injection if you're going to do an optical coherence tomography. So what we did is we went ahead and started, putting in our stent, and wanted to go all the way back to the left main. We stented it. And this was actually several years ago. And as we did proximal optimization in the left main as we kept going. But you can see that you can keep chasing yourself, and you can put a second stent and a third stent and so on, and you'll just keep doing it. We put in a second stent in this patient, and then this was the result after the second stent. But since we had good flow, and miraculously, she started to show some hemodynamic improvement just by tacking up that proximal segment, we opted to stop but keep the mechanical circulatory support in, although she was starting to make a turnaround at this point in time. And you can see that the flow in the LAD was starting to show a little bit of improvement, but again, it's not a normal LAD. There's clearly a hematoma in the wall. So over the next 5 days, we weaned her off the Impella mechanical circulatory support. She was conscious, oriented, and her oxygen saturation was good. She never required ventilation, mechanical ventilation. It was really all circulatory support. After we removed her Impella, we started guideline-directed medical therapy for LV dysfunction. We had implanted stents, so naturally she needed dual antiplatelet therapy, although the guidelines for SCAD per se don't require it. And, we opted to reassess her in 1 month. We did start her on a smoking cessation program, recommended genetic testing, reassessed her echo before discharge, and I'll show it to you, and then probably continue titrating guideline-directed medical therapy. But she did need screening, obviously, for fibromass, FMD, and the rest of her family. And given that she's 31 years old, the next question would be the next pregnancy and future pregnancy. So as you can see here from her echo, her anterior wall got a significant hit no matter what we had done. So there was significant LV dysfunction, and this was just before discharge. And there's a lot of data back and forth about how women do in terms of cardiogenic shock with mechanical circulatory support. There are some baseline differences that we can gather between men and women, whether you're looking at body surface area, hypertension, and other risk factors, and other conditions such as atrial fibrillation and COPD. Interestingly, in this particular series, women and coronary disease, fewer women had more women had end-stage renal disease. But when you actually look at the mechanical support, auxiliary access would have been ideal in a woman like ours who can ambulate and is conscious and is oriented. Nevertheless, we were femoral because it was a shock, and we just went in with the best that we could. And then looking at AMI versus non-AMI shock, what is the most common presentation? So in this particular series that was published in Circulation, non-acute MI shock was actually the leading indication for MCS in both sexes. And what you can see is that women receiving CP was more frequent than the other bigger mechanical circulatory support devices. So when you're looking at even Impella 5.0, the 38% of men had it compared with 8.1 in women. And VA ECMO likewise, you're looking at women 14.6 versus 33.1. In terms of bleeding and other vascular complications, there's a trend to have higher complications in women compared with men. And I think it is something for us to consider, especially for patients who are going to require longer-term mechanical support, such as postpartum or SCAD. I mean, we were lucky that she recovered within a week and we could wean it off. But part of the reason we did rush to wean her off is we were having vascular issues. And although we were doing antegrade perfusion, she was already starting to develop ischemic leg. So in hospital mortality, we're looking at very similar, although again, there's a trend for it to be higher in women compared with men, and again, surviving quite similar compared with men. But I think understanding that the survival rate and mortality rates are similar between the sexes, and yet there's a reluctance to offer it. This is an elegant paper that was published in 2022 addressing vascular access in patients who are receiving mechanical circulatory support, and what we should do, not only how to gain access, but to how to improve circulation while the limb perfusion while the patient is requiring MCS, and whether it's doing distal limb perfusion, whether it's optimizing their anticoagulation, and so on. And finally, this is the one question that, the 2018 American Heart Association guidelines and other statements actually don't recommend future pregnancies. They discourage it. And part of the reason is the recurrence rate ranged from 2% to 22%. And there's no effective manner to predict a SCAD recurrence, unfortunately, other than understanding what the genetic background is. And then multiple studies, whether in pregnant or non-pregnant women who are already postpartum, compared with other patients, they tend to have multivessel disease, left main involvement, and cardiogenic shock, which is why we're inclined to discourage our patients. Concurrent fibromuscular dysplasia can confer additional obstetric risk, for example, gestational hypertension, preeclampsia, and preterm delivery. And those are the reasons that we should reconsider a future pregnancy with our patients. Nevertheless, there are reports out there where women who have had prior SCAD and then went on to get pregnant did fine. So I don't think we have enough evidence, but for now, most of us would be discouraging women from getting a second or third pregnancy.
Thank you, Mirvat. That's an amazing case. And I think do we have a little, yeah, we have a couple minutes to talk. So very quickly, I would like to, I'm going to pick on Suzanne because I always pick on Suzanne. Can you just comment on the approach? So, this was LAD. It did look like the left main was involved. You said proximal LAD, but it was clearly going into the left main. And you're avoiding imaging, right? So I'd like your comment on the use of imaging in these patients. And then also the very kind of limited stenting that you did, right? You did the left main proximal LAD, and you can see that as you said, you're chasing it down the vessel. So basically what you're doing here, the strategy is open up the vessel, make sure there's flow down the vessel, and then keep the patient on MCS. But I just wanted, Suzanne, could you just comment on that approach? Use of imaging and sort of like, should we be just doing touch-up, direct stenting, minimalist approach?
Absolutely. Well, first of all, Mirvat, incredible case and amazing that getting this patient through. I think this type of case is like every interventionalist's nightmare. You have a young woman who is in shock with SCAD, and we know that generally, with SCAD, it will heal on its own. And so we try to leave it alone. But as clearly evidenced in your case, this patient was in shock. She was not doing well. And your hand was forced essentially to consider proceeding with stenting. I'm a big intravascular imaging proponent. I'm with you with regards to diagnosis of it. I don't think that was necessary. We knew what was causing it. It was clear from the angiogram what was causing this. I would probably consider intravascular imaging after the stent was placed, at least to just confirm in the left main that everything was appropriately expanded and sized, just because the stent did extend back into the left main. Again, always easy to say that when you're not at the bedside with someone in cardiogenic shock on an Impella sort of thing. But, if you had a couple minutes and it was improving, maybe right at the end, just making sure that the left main was ideal, I probably would consider that. And some of the guidelines do suggest that for complex scores, but I completely agree that, there was no question about the diagnosis. So refraining from the get-go made sense.
Great. Thank you. Thanks, Suzanne. And then I'm just going to ask Josephine very quickly, if you don't mind, to address sort of the follow-up here and the issue of, what our recommendation should be for, should we be telling these patients not to get pregnant, and how strong of a recommendation, if the patients do want to get pregnant, how do we, because that's the challenge, right? How do we follow them? What's the follow-up there?
Yeah, that's a great question, Mirvat. I echo Suzanne's congratulations on this case. This was a tough case, and kudos to getting her through. And pregnancy after a case like this always makes everyone gives everyone some high blood pressure and some palpitations through that. And pregnancy is unique because it's one of those conditions we can't keep people from doing. They either get pregnant or they don't, and it's a very personal decision. And the way I approach counseling for these patients is I quote the similar statistics that you've cited, that the recurrence rate is high. We don't have a great way of predicting the recurrence, nor do we have a great way of any kind of preventive measure like medications and whatnot. And after counseling them on that risk, I try to assess how important this pregnancy is to them and whether that benefit of the pregnancy is worth the risk per se. And each person does have their own individual assessment of that. And we try to support the patient through that decision making so that they're comfortable with that decision. For those who have decided to proceed with a pregnancy, there is a lot of breath holding. There's a lot of serial EKGs, a lot of serial echoes, beta blockers, even though there's not really great proof for that. I think it makes us feel better more so than actually improving outcomes. And then delivery at a tertiary quaternary care center with teams experienced in caring for patients with SCAD. So you want interventional cardiology as backup as well as CT surgery. You want maternal fetal medicine and high risk obstetrics delivering these patients so that in the event something does happen in a recurrent event, you have the teams who have experience in caring for these patients there with you. So,
and is that sort of natural delivery or is it C-section or
it depends a bit on the case. So Valsalva and pushing would make a lot of people nervous. So there is something called an assisted second stage where patients don't have to push quite as much. An epidural for pain control is strongly recommended. I think there are people who may recommend a primary C-section if there's been multivessel disease or LV dysfunction. I don't think that's necessary. That's wrong. C-section does come with its own sets of bleeding risks and higher anesthetic requirements. So it's a risk-benefit assessment with maternal fetal medicine and OB anesthesia as to which modality of delivery would be safest for the patient.
Okay, great. Thank you. Some really good takeaways there. Thanks, Mirvat. Really appreciate the case. All right, we're going to move on. Hari is going to present his case. And again, I think it's going to bring some really interesting points to discuss here.
All right. So great case, Mirvat. I'm going to present a little bit different case here. I want to give credit to my fellow who helped me with these slides in this case that we had recently. So this is a 59-year-old woman, so middle-aged, with coronary disease, had multiple prior PCI to the LAD, CIRC, and the RCA, hypertension, hyperlipidemia, COPD with a recent COVID pneumonia with prolonged rehab stay. So she had significant lung disease, but she had preserved ejection fraction at that time and presented to outside hospital with shortness of breath, cough, and fatigue. So she was initially hypoxic to the 80s and improved with some oxygen. The CAT scan showed bilateral ground glass opacities, but because of her lung history, this was felt to be pneumonia on top of moderate severe emphysema, but no PE was detected at that time. She was given duonebs, IV fluid, and started on empiric antibiotic, and the lab started coming back in the vitals, as you can see here. She was tachycardic. Blood pressure was preserved at 139/82, not too bad of a pulse pressure. Temp 36.5, SATs 95% on 4 liters of oxygen by nasal cannula. So not too bad. But the lab started coming back. The white count was a little bit elevated. Lactate was 2.7. So now we're starting to think about shock or something going on with hypoperfusion. ASD, ALT were 48/35. Creatinine was preserved. Troponin was relatively low, and BNP was 1300. Patient got an echo the next day, so not the first day, but the next day after getting fluid and antibiotics, and it showed a newly reduced ejection fraction of 25%, so globally reduced function, and now with moderate to severe global hyperkinesis and moderate to severe MR and moderate TR. So due to uptrending troponin at that time and lactate, patient was transferred to our center with a diagnosis of non-STEMI and acute hypoxic respiratory failure, as well as a low EF. And it was thought at the time that it was either septic shock, cardiogenic shock, or a mixed shock based on the confluence of these factors. So there's the echo on arrival to us. The echo showed global hypokinesis. You can see the RV side is okay, but the LV is dilated and also hypokinetic to 25%. On the right, you can see that there was a significant amount of MR, at least moderate to severe, partly contributing to the situation. The lab started coming back. You can see the lactate on the venous gas was 7.2. You can see the BNP was elevated to almost 3,000. Troponin now creeping up to 1,300. And you can see that, fortunately, the B and creatinine was still preserved at this time, so that, that lags behind. But it's nice to see that that's still normal by the time the patient was at our facility. A little bit elevated AST, indicating some involvement of backward flow into the liver. On the right, you can see the white count was elevated, hemoglobin, however, was normal, and the lactate by arterial gas was 4.1. So this patient was quickly taken to the cath lab for a right heart cath. Actually, this might have been done at the bedside. RA9, RV52/3, PA49/25 with a mean of 32 with a wedge of 22, so a transpulmonic gradient of 10. PA-SAT was low at 58%. Up by FIC, you get an index of 1.8, and by TD 2.4, but certainly reduced compared to what you'd expect it would be normal. PAPI was preserved at 2.6, so there was not significant RV involvement, as you can tell by the echo as well. So in the cath lab, the patient got angiogram, and you can see a lot of things here, which is the stents have significant disease, TIMIA 1 to 2 flow in the right. See the marginal is also affected, acute marginal on the left side here. You can see that the significant in-stent restenosis of the circ system, as well as the LED system, a lot of diffuse disease and relatively small caliber vessels using this 6 French technique, 5 French technique. Now, one of the complicated factors we can talk about is that the femoral and the iliac system has severe disease, and so it was hard getting up. But you can see here that because of this precluded the use of balloon pump or mechanical support, as is often the case in some women, something we can talk about as well. So the decision was made that this patient was contraindicated for mechanical support due to severe PAD. Both balloon pump and impeller were not used at the time. The thought was to try dobutamine and diurese the patient for volume optimization and see if that works. Surprisingly, it did work, and she did clear the lactate and was ultimately extubated 2 days after arrival here. One day after arrival here, 2 days after the initial presentation. At that point, as she was getting better and extubated, CTS and heart failure evaluation for CABG was performed while on inotropes. This is our heart team discussion in our institution, and we are a transplant program as well. As part of that workup, she had a CTA that showed severe PAD that made her not a great candidate for advanced therapies, and also a poor candidate for CABG, along with her known severe COPD and emphysema. So the plan was ultimately at that time, that team discussion was done pretty quickly, but the plan was to pursue high-risk PCI and GDMT once respiratory status improves. So we're trying to keep the patient, I think that we're trying to keep the patient extubated and see if this can be done by just continued diuresis and improving her overall clinical state to make her a better candidate for PCI. And the PCI would not be a slam dunk, but certainly could be done. So the next 4 days, this is where I think we can talk a little bit about, is that her respiratory status remained tenuous during that time, even though we're pretty aggressive in our CCU by getting these patients better. This is pretty much all we do. She was unable to lay down, and she continued to have off and on pulmonary edema along with some component of anxiety, or was thought to be component of anxiety, continued diuresis, but could not wean the inotrope. So she stayed on that. She also had a psychiatric consultation for the anxiety, which I think made her a little bit difficult in terms of cooperation as well. And so I think, in retrospect, how much of this was worsening heart failure again, or waxing and waning heart failure versus, primary or secondary anxiety component. So after the multidisciplinary team again, at that point, the plan was to electively intubate her, which makes sense, to take that off the table, place an axillary balloon pump, and then go ahead with the multivessel PCI while on the inotropes as well. So add the balloon pump for procedural support. However, overnight, and this is the 4th day, patient had PA arrest, then had subsequent VFib reported on the rhythm check, where she was shocked, but ultimately patient passed away. So a little bit different than some of the other cases, this patient did not make it. And so we're going to have some discussions about that. So some key points I want to talk about here is, what went right in a way. The time to diagnosis, that didn't go right. She had atypical symptoms and relatively normal labs except for the lactate, and that didn't come back right away. And so at the outside hospital, this was pretty much a misdiagnosis of COPD, emphysema, pneumonia, because of a recent admission for that as well. And she was also given a lot of fluids for presumed septic shock, and there was no echo done at that time until the next morning. So there was a delayed diagnosis of shock, a cardiogenic and etiology, and a mixed shock population at that. Number 2, the time to intervention at our hospital, she did get an early echo and did get early inotropes, and she also had lactate, and she went quickly to the lab and got a PA catheter and left heart cath. So we had the diagnosis, and we had started support. And actually, if you look at the bottom right here, she did have her lactate cleared in 24 hours. So you can see the lactate at the other hospital, 2.7, then went to 4, transferred over. By the time she got to us, 7.2, as I mentioned. Then the next day, so within 24 hours, even from the outside hospital, we were able to clear the lactate to 2.4. And as you can see, that it's kind of sputtered there, 2.4, 2.3, which we sometimes see if the liver is involved. But in general, it wasn't re-rising, so that still qualifies as more or less lactate clearance at this point. So that worked out well as well. However, she did not get mechanical support at the time of the procedure for the reasons that we discussed. And at the time, we did not do sort of urgent axillary support. We wanted to get the heart team involved. And the CABG versus PCI decision was delayed a couple of days to try to optimize the patient, and probably because she was initially getting better. The lactate cleared, she got extubated, and she was diuresing, and the creatinine was doing okay. So it gave us a false sense of security that you may have had more time. And ultimately, this anxiety component versus whether it was really clinical deterioration is worth talking about, because although there is anxiety, everybody has anxiety, but I do think that sometimes that delays things more in women than men, potentially. And so we should talk about that. And ultimately, the patient expired, even though the decision was made to be far more aggressive towards the end of that discussion. So 3 key points, I think, from the document we can talk about. Number 1, that early and frequent assessments of end organ function, including lactate, and early PA catheter use in women assist early diagnosis and management. And that happened here. So the patient got frequent assessments, and the lactate was clear within 24 hours. Number 2, in women with shock, aggressive escalation of vasopressors and inotropes at the expense of delays in MCS should be avoided. So this was a conscious decision, but you could argue that maybe the balloon pump should have been put earlier. That being said, she still did clear the lactate within the 24 hours, so it probably did okay. But the same discussion comes up about the risks of vasopressors and inotropes. She didn't get vasopressors, but inotropes in the setting of shock, and whether that made things worse as it made things better as well. So I would say it was not achieved. Number 3, women are less likely to receive aggressive AMI shock treatment and undergo less primary PCI compared with men, despite the fact that early culprit-only revascularization is the mainstay of therapy in shock and improves mortality. So she did not get this, and I think it was not unreasonable to wait for CABG and optimize, but nonetheless, she was not revascularized, and ultimately, this also highlights that if you wait a little bit, even if it's just 4 days, some bad stuff can happen. So I'm going to leave it there and open up to discussion, but I want to thank you all for the opportunity to be here.
Thanks, Harry. I think you're absolutely right. I mean, this patient's sort of a nightmare patient, right? She's got extensive coronary disease. She's got a non-STEMI. Oftentimes, non-STEMI patients have way outcomes than STEMI patients. She's got extensive peripheral vascular disease, and I think, you know, the whole concept of getting the heart team involved sometimes can delay things. And, you know, there was a clinical improvement, at least based on biomarkers. So let me just, from our panel, I'm gonna maybe Anna, you want to comment. So, you know, we always learn from these cases. I think that's the whole point of this. So what could we have done differently? You know, I think maybe it's obvious, but I think it's worth, you know, perhaps commenting on that.
Well, probably the only thing that could be done differently would be up the level of aggression earlier to do a high-risk PCI on support that might end up in a vascular complication, and knowing and tolerating that might happen. So as this person's turned down, then we need to escalate the support in order to actually adequately intervene. And that may mean that vascular surgery needs to be involved. We may end up, you know, having an acute limb event in addition. And that requires having consent from the patient. And can the patient really understand in their acute shock state these kind of heavy questions? One of the things I put in the chat is, you know, we don't have enough women in trials in shock, but how can we really get consent, you know, from the shock patient? What can they understand of the decision that they're weighing? So many times a surrogate decision maker is deciding for them. And so this is also challenging for us.
Yeah, for sure. I mean, the whole consent issue is complicated, takes forever. It takes a long time to be able to get these assent, you know, to get consent after the fact. If you cannot get it from the patient or from the family, it just, is massive delays and an obstacle clearly in enrolling these patients, particularly in the US. That's the reason, I think part of the reason why most of these clinical studies are being done in Europe, where I think it's a much easier pathway to go. Amanda, I'm gonna just maybe ask you to make a comment here before we go to the next case.
Yeah, incredibly tough case, and I agree, in retrospect, maybe moving slightly earlier to intubation and auxiliary support might have been something that had changed the course. I really have a question for Dr. Nadeau. What do you think actually occurred when she electrically fell apart? Because there are a few possibilities there, presumably, right? Was it, because you showed how the lactate had settled down, was it a new coronary insult? Was it an arrhythmia in the setting of the inotrope use and some
Yeah, no,
scar
none of that happened. I think it may have been respiratory and either
drove the
plugging or
situation?
something that happened
Yeah.
that all of a sudden got her more hypoxic and had to be intubated. But then in that setting, she couldn't tolerate it and spiraled. And that's one of the challenges. These patients spiral very quick if one thing happens. I think in retrospect, we may have wanted to do like an Impella 5.5, have the surgeons put that in. Because I think we thought about balloon pump for support. Balloon pump's not great support. It helps a little bit in the balloon pump trial, that it helps some procedural complications. But it might be that the reserve is so low here that you just have to have something that if stuff hits the fan, you actually can carry them through. And we do a lot of 5.5s. So I think maybe we still got scared of the 5.5 in a woman, but typically they should be able to tolerate that from the top.
Exactly.
So.
In an auxiliary location, I mean, our standard is a 7mm axillary artery there on ultrasound mapping, trying to do that early on when they come in.
Yeah, we do tons of it. I think what happened is maybe the heart team and the surgeon stepped away, and then we didn't call them back for maybe a compromise, which is, well, you can help us. But I think these are the questions that arise that you have to a little bit deeper in terms of that.
And I thought it was very pressing, the question you sparked about her abnormalities of mental status, appearing agitated. I think we see that very frequently as the clinical sign that shock is occurring, especially in the setting of a bit of a resurgence in lactate. And I don't know if women are more commonly affected by this, but I've certainly seen it many times in women in the middle of the night getting into that respiratory situation, and it's their main.
I think so. I think when they get more anxious, they're telling you that that's one of the ways they're telling you that they're doing worse. And I don't have the data here, but it seems like that might be an earlier symptom in women more, and we have to take that seriously as clinical deterioration. Maybe that's when the patient should have been intubated, re-intubated. And then take the hypoxia off the table, and maybe, but you don't know all these things in retrospect, but I put that in there because it was part of it, and people should be aware of different signs and symptoms by gender.
And that's the reason why it's so important to do these presentations, discuss it, and really dig into what's going on in these patients and discuss, what could we have done? The outcome may not have been different, but I think it's all, teaching points here and improving over time what we do. All right, so we're going to move on to the last case. So Anna Bortnick has a case for us, and
Miss Kristen Perry is going to be my hands.
Oh, yeah. Okay, good.
Okay. I'm going to present to you a rare case, which I'm calling Catch-22. This is a 65-year-old woman who presented from an outside hospital. She had had a fall with significant shortness of breath, and she was very hypoxic. And there she was started on 5 liters nasal cannula. She had declined hemodialysis, but it wasn't clear the last time she was dialyzed. And she was an end-stage renal patient who was dependent on dialysis. And the CT angio there showed multiple subsegmental acute PE, some pleural effusions. She had an extensive past medical history: sickle cell disease, the end-stage renal disease, heart failure with preserved ejection fraction, hypertension, and significant peripheral arterial disease, with amputations of 3 of her limbs. So she had a left above the knee, a right foot, and then her left 2nd through 5th fingers were amputated. She also was actively smoking and living in a nursing home. Let's go to the next slide. I was called by the on-call fellow because they found she had a massive, let's go back. There might be some automatic stuff happening here. But she had a very large pericardial effusion and some RV collapse. Obviously, her left heart is thickened but functional. And you can see massive, right atrium. And they asked if we could decompress her effusion and help with this situation where she was hypoxic and mildly hypotensive. Let's move on. So coming into the hospital, I had a sense of reluctance. And this was because she had some moderate pulmonary hypertension at baseline. She also had this acute PE scenario and now tamponade. And I felt like her right heart wasn't completely functional. And so I was concerned about doing full drainage of the pericardial effusion. And this is because rarely, if you decompress a dysfunctional RV that's under pressure, that RV can rapidly expand and then become fulminantly dysfunctional. And so my strategy here was to obtain a right heart catheterization, to evaluate her hemodynamics, and maybe to slightly decompress the effusion without removing all the fluid. So before the fluid drainage, her baseline right-sided pressures were severely elevated, and she had a wedge pressure of 18. Her PA saturation was 47%. Her index was 1.75, and she had a PAPI of 2.3, and the cuff pressure was 108 over 58. It was kind of reasonable. Let's move on to the next. Okay, so pre-pericardiocentesis, this is in the lab with the right heart catheterization. You can see that there's a dilation of the right side of the heart. So I want to point that out. So this is not completely a normal RV. Let's move on to the next. And so we did a very slow drainage, and it's not really clear how much we should drain in this scenario. So what we did is just a slow drainage, and we took 170 milliliters of sanguineous pericardial effusion and obviously sent that off to the lab. And then we reevaluated the numbers, and you can see the PA pressure has now come down. The wedge pressure has increased from 18 to 31. The cardiac index is holding, but the PAPI has also declined significantly to 1.4. We can go to the next slide. 13 minutes later, the blood pressure, cuff pressure is now significantly different. She's now requiring pressors where she wasn't requiring much before. So she went from 5 to 20 micrograms per minute of Levophed within 20 minutes. We had to add vasopressin. And we had to continue to uptitrate the Levophed. And we had to add dobutamine. We had a fulminant change in this patient's physiology with a low volume decompression of the pericardium. And we also noted that she had hyperkalemia and metabolic acidosis on a gas that was taken in the lab. So we treated this with bicarb. Next. And she had some bradycardia. So as you can see, she's trying to have PEA arrest. Okay, let's continue. And we placed a femoral A line. And we also placed a trialysis catheter as we felt that she would need emergent hemodialysis to correct the metabolic abnormalities, maybe to decompress and decongest the heart because of this elevated wedge. And we did all of this kind of in consultation with critical care and our heart failure team. Okay, let's move on. So here's our post-pericardiocentesis. You can see this RV looks even more dysfunctional as compared to, let's go back one, the pre-pericardiocentesis. So even just removal of this low volume has changed the function and physiology of the right heart dramatically. Okay, we can move on. So this is a case I've really never seen before. It's something that I had thought about. It's something I was concerned about in a theoretical way, but I had never actually had to experience that. And I went to the literature and looked up, what they think the mechanism is. It's not entirely clear, but there's some thought that this is a decompression syndrome where the RV is suddenly kind of released from its pressurized state, and now there's increased venous return, and the RV simply can't handle it. It impinges on the left side, and you get decreased left-sided performance, and you end up with significant shock. Now, in the right candidate, you could put them on ECMO, but this patient has amputations everywhere. She actually had no access for that. And, putting in a right-sided microaxial flow pump into a person who has severe pH it's not going to work very well. So there really wasn't going to be a good strategy for mechanical support for this individual, except maybe doing something from above on the right and left side. But what is going to be the exit strategy for that patient if they're not going to be a transplant candidate, for example? So let's move on. So, looking further into this pericardial decompression syndrome, it has very high mortality. Actually, that's a percent, 20% mortality in a systematic review, 50% mortality in the national inpatient sample. It's reported most often in women with connective tissue disorders. And there is an unclear best practice here for safe drainage. The ESC recommends limiting drainage to 1 liter, but 1 liter is actually large. And so others have suggested maybe using a pressure transducer attached to the pigtail and to serially withdraw until the pericardial pressure falls below a certain level. So very, very low volume. However, what that volume should be is unclear. And in this case, we did a low volume tap and it wasn't effective, which is why it felt like a catch-22. Let's keep going. Just, to illustrate that RV shock, biventricular shock, in women versus men, women have worse outcomes across the board. Keep going. And so this is really to drive home that point about how much different women do and what their odds are. They're 60%, about 60%, more likely unadjusted to have worse outcomes. And even if with the adjusted outcomes, it's even worse. With right ventricular shock, they end up with an odds ratio of 2 for mortality. So I think that this is an interesting point that I didn't really know about. And so lastly, when we think about how people die from pump failure with reduced ejection fraction, that's one kind of limited list. But when we think about how they die from pump failure or fulminant shock in preserved ejection fraction, that list is much more complex. And so I think this is also illustrated by this case. Next. And so she actually sustained a recurrent event, and they pulled all the fluid off during that event. Started her on epoprostenol to reduce the PA pressures, did emergent dialysis, and she survived for a period of days, but had a recurrent bradycardic arrest days later. And after 10 days, the family decided that they would pursue palliative extubation. And so I think that this is a dramatic case of RV shock. It really drives home the point of how difficult it is to take care of women in shock and how they present and how much more complex they can be. Thank you.
Thanks, Anna. That's an amazing case. I have to say, I have not taken care of anybody who had this entity, and I wonder if anybody on the panel has. Amanda?
I had one very early on when I was a first year attending. She had lung cancer and she had an effusion lap big, and we actually drained it all off because I was a first year attending and didn't know anything. And she developed exactly what you showed. Her RV became big and dilated. It was very dysfunctional. We actually put her on pulmonary vasodilators first, and she did survive. And I never knew the name to what I saw until you just presented that. So thank you for giving me a name to that syndrome.
Yeah, I mean, I think I'm sorry, go ahead.
Well, I was just going to endorse that. That's one of the challenges here, right? Because presumably, to make it clear for everyone, we presume that this lady had long-standing pulmonary hypertension with a dilated and dysfunctional RV. And yes, maybe the RV collapse wouldn't have been so profound if she was on inhaled epoprostenol, for example. But this wasn't a really lady where we could do that because her wedge was already in the 20s when you first met her. And heck, it shot up to 30 when you started draining the effusion. And we know opening up the pulmonary vasculature with an inhaled vasodilator like that can flood the heart and further drive up the wedge. So a really very difficult situation to get out of hemodynamically here, sadly.
Any role here for right-sided MCS?
I
I
think that
think
would
you
have
would need
been
biventricular.
challenge.
I think you would
Right.
need to have like a Protect Duo and a 5/5 pulling at the same time, which is why I said it's ECMO, right? This is an ECMO scenario. But in a patient who has this level of PAD with 3 limbs amputated, there is no access for that. And also you have to think about the exit strategy from the support. So something that we always think about is, what's the survivability? This is a transplant patient? Is this somebody where we will be able to wean this level of support, because there are complications from that, stroke, limb ischemia? It has to be, a scenario where you may see an exit strategy. I'm thinking of a case, and this would have been the alternative case I would have presented to you, but I had a patient who was on ECMO and spent 8 months in the hospital. So, just to illustrate, when you get into mechanical support, the exit strategy becomes also very important to think about.
Yeah, I think that's a really important point. All right. Well, I think these were 3 amazing cases. We have 1 minute. So I'm gonna pose the last question. And that is, should we be doing trials? I think the document that Suzanne, went through really identifies key areas, which is most of the areas in cardiogenic shock. And obviously, we're not going to be able to do clinical trials in areas such as the case that you just showed us, because they're so uncommon, but there are much more common scenarios with shock. So here's my question to the panel. Should we be doing in AMI cardiogenic shock after danger, right? I'm going to bring you back to that. Should we be doing a clinical trial in women only? And should we be randomizing women to repeat or to document the benefit for women? So that's my question. Anna, you're gonna start first.
Okay, I'm going to make the point about the consent, right? That's point number 1. Number 2 is going to be, we already know we're going to have vascular access issues more often. Number 3, the question is randomized compared to balloon pump, compared to pressor. So
I would say repeat danger shock in women only.
okay, yeah. So I think that that you're definitely going to see more vascular complications. And then I think the consent process, it has to be clarified. We have to find a way to do this. We have to overcome this hurdle. Otherwise, we're not going to be able to advance the study of shock.
I totally agree. Josephine, it's a yes, no, because we're 1 minute over.
I echo Anna's concerns. I think in theory, yes, that would be very, very helpful. But I think there are a lot of challenges that would stand in our way.
Okay, let me say, Amanda, would it be ethical to do a randomized clinical study?
It's a great question. I think it would be incredibly difficult logistically to do, but I think one could argue that there's equipoise because of, the forest plots we saw on that, the women, which were underrepresented, were the only group that didn't show that they were necessarily benefiting. And we know that we have this greater concern around limb injury and potentially even bleeding that does balance out the equipoise. So I think it's ethically defendable.
Okay. Suzanne?
I agree. I think it's ethically defendable, but I think the logistics are going to be what kill us. Certainly in the US, I think it would be largely impossible for us to do this study with danger shock out there. But I think we do need to figure out a way to get more data in this patient population for sure. So maybe whether a single-armed registry, at least to just understand more about what's going on, may be helpful.
Okay, so Mirvad, I'm going to change the question. If you were to design a clinical study to evaluate women, because we all agree we've got to do that, would it be all comers? Would it be just AMI shock? How would you do that?
So unfortunately, shock in women is very diverse. I mean, there's variable etiologies and the outcomes are very different. So when you're looking at postpartum, when you're looking at decompensated acute heart failure, it's quite different than AMI shock. So I don't think all comers would give us the answer. And just one very quick point about, repeating the danger shock in women. I think if we add a protocol for vascular access, we do have contingency plans now. We do have protocols that allow for antegrade perfusion, where we titrate down vasopressors to reduce the incidence of limb ischemia and so on. So if we have a protocol that addresses that very directly, and we do have now some novel devices, microaxial pumps that are smaller profile. So I think maybe if we're looking at a protocol that actually addresses these issues head on, it may help us get some answers.
Okay, well, thank you very much. Mirvat, you've got the last word because our president has left us. He's left our panel. So I want to thank all of you. I think this was really phenomenal. Thank you so much. Thank you for the cases. Thank you for staying up till 4 o'clock in the morning for joining us. And let's do it again. Thank you.